Good day, and welcome to the CAP webinar entitled The Proposed 2026 Medicare Policy and Payment Changes for Pathologists. During the next hour, we will discuss the proposed regulations and policies for the Medicare Physician Fee Schedule and the Quality Payment Program that will be used to reimburse pathology services in 2026. Before I get started, I'd like to review a couple of technical details about today's presentation and also introduce our presenters. Please type your questions during the presentation. There will be time at the end of the presentation for our panelists to address your questions. We will select questions from a representative sample of those submitted today during our limited time here today. An archive copy of the webinar will be available later next week. The CAP will have a link to the presentation along with a PDF of the slide deck in the webinar section of the cap.org website. Now, let me take a moment to review our agenda and introduce our presenters. Your moderator for today's webinar is Pamela Yazdani. Ms. Yazdani is the Senior Director of Economics and Regulatory Affairs at the CAP's Division of Advocacy, located in the CAP's Washington, D.C. office. Our next presenter is Dr. A. Joe Saad, Chair of the CAP's Council on Government and Professional Affairs. Dr. Saad is also a member of the CAP Board of Governors, Chief of Pathology for the Methodist Health System in Dallas, and Adjunct Associate Professor of Pathology at the University of Texas Southwestern Medical Center. Our next presenter is Dr. Ronald McLaughlin, who is the chair of the CAP's Economic Affairs Committee and a member of the CAP's Council on Government and Professional Affairs. Dr. McLaughlin is also professor and vice chair of pathology, head of the Division of Laboratory and Genomic Medicine, and director of the clinical laboratories at University of California, San Diego and UC San Diego Health. And our final presenter is Dr. Gregory Bucci. Dr. Bucci is the chair of the CAP's Value-Based Programs and Healthcare Policy Committee. Dr. Bucci is an associate professor of pathology at the University of Colorado School of Medicine. And now it is my pleasure to introduce Dr. Saad.
Thank you very much, Ms. Yazdani, for that introduction. During today's webinar, we're going to go over briefly the overview of the payment and policy and advocacy of agenda of the CAP. Then we're going to discuss the proposed 2026 fee schedule changes. We'll then look at the pathology code's impact and outlook for 2026 in more detail, and also in detail review the proposed 2026 quality payment program policy. Finally, as mentioned, at the end, we'll have time for questions. So the proposed 2026 Medicare Physician Fee Schedule and Quality Payment Program regulations were released on July 14, 2025. Later that evening, the CAP members received a special advocacy update with the initial analysis of this regulation. Today, we're going to go into a little more detail about the regulation, and we will continue to engage with the CMS over the next several weeks until the final rule is released in November. But during the comment period, we'll be submitting comments to CMS over their proposed fee schedule. And the final regulation, once released in November, will be implemented on January 1, 2026. The CAP, AMA, and other physician specialties are pushing Congress hard to fix Medicare cuts for good. Over the last 10 years, payments to pathologists have decreased by 9%. At the same time, practice costs have increased nearly 24%. This proposed rule continues to worsen the gap between payment versus practice costs. The problem is mostly attributed to a lack of an inflationary update to the physician fee schedule. And according to the AMA, physician pay fell 26% between 2001 and 2023 because physicians do not get a yearly inflationary update. This is opposed to others that are paid under Part A of Medicare, such as hospitals, long-term care facilities, skilled nursing homes, ambulatory surgery centers, etc., they all get an inflationary update. Physicians do not get an inflationary update. The CAP is estimating that the average pathology Medicare payments are forecast to increase by 0.56% for 2026. At the same time, as I mentioned, physician practice costs are up by 24% since 2017. As you can see on the graph here on the right-hand side, this delta between inflation and payments is approaching 33% for 2026. This is unsustainable and cannot continue. You can see a tiny blip up in the blue line for 2026, that 0.50% increase, but look at how much inflation has continued to outpace physician reimbursement and actually the decrease in physician reimbursement. This is totally unacceptable, and this is due primarily to a lack of inflationary update. So as you may recall, with our previous Hill Day, this was one of our prime asks, and we will continue to push hard Congress to fix this. And with that, I would now like to turn the presentation over to Dr. McLaughlin. Thank you.
Thank you, Dr. Saad. Could I have the next slide, please? So there is a lot to unpack from the proposed rule. The conversion factor did increase by 3.3% for 2026, but this increase is only temporary and does not reflect the true impact on pathology. The increase is temporary and is largely driven by the One Big Beautiful Bill Act, which will increase overall physician spending by 2.5% for 1 year only. The proposal that's announced in the release will impact pathologists very differently and depend on a variety of factors, including case mix and practice type. However, on average, pathology will only see a 0.56% increase in 2026. Independent laboratories, on the other hand, will see a 1.31% increase. I will get to why pathology sees such a diminished increase in the subsequent slides. Next slide, please. So starting in 2026, CMS is proposing to split the conversion factors based on whether a physician is a qualifying participant in an advanced alternative payment model, or APM. As required under the Medicare Access and CHIP Reauthorization Act of 2015, also known as MACRA, physicians who are qualifying participants in APMs will receive a slightly higher conversion factor update and thus slightly higher Medicare payments in 2026 compared to physicians who are not qualified participants. Both conversion factors are adjusted by a positive budget neutrality adjustment, largely from the efficiency adjustment proposal that I will discuss on the next slide. The proposed 2026 conversion factors are listed here for qualifying APMs and non-qualifying APMs. This translates to about a 0.5% increase to qualifying participants. Next slide. The CMS expressed concerns about productivity efficiencies not being accounted for in current work RVUs and non-time-based services. CMS noted that diagnostic tests, radiology, and other time-based services should become more efficient as time goes on and become more common. Professionals gain more experience, technology is improved, and operational improvements are implemented. As a result, CMS is proposing an efficiency adjustment by decreasing the work RVU and intra-service physician time for non-time-based services by about 2.5%. This adjustment is arbitrary in nature, but based on using the sum of the MEI, the Medicare Economic Index, productivity adjustment over the last 5 years. MEI is typically viewed as a measure of practice cost inflation. Adding additional concerns, CMS indicated the approach is conservative. and they may consider making additional updates to PE inputs, such as reducing clinical labor times. Further efficiency adjustments are also proposed to occur every 3 years. This proposal is based on the premise that physician time in the RBRVS, the resource-based relative value scale, is inflated, with the criticism of utilizing physician surveys to estimate physician time, specifically around the AMA RUC valuation process. Next slide. The efficiency adjustment will apply across the full spectrum of pathology services, including key CPT codes such as high volume surgical pathology and cytopathology services such as the 88305, 88312, and 88342. So basic surgical pathology codes, as well as special stains, immunohistochemistry, so forth. As an example, the work RVU assigned to 88305 is proposed to decrease by 0.75 to 0.73. Interestingly, this adjustment also impacts the pathology clinical consultation codes, the 80503 to 80506 family, which are actually time-based or based on medical decision-making complexity. Both global and professional component -26 modifier services payments will be impacted by this policy. Next slide. So in terms of practice expense, hospital physicians are most at risk from CMS's proposal to reduce indirect practice expense reimbursement to services provided in the facility setting. Many of these services, pathology services, including surgical pathology, are not currently subject to this proposal, but some services, such as bone marrow, blood services, consultations, and apheresis, are definitely impacted. Under the current practice expense methodology, CMS allocates the same amount of indirect cost independent of facility setting based on assumption that physicians maintain an office-based practice when practicing in a facility. Presenting evidence to challenge this assumption, CMS argues that allocating the same amount of indirect practice expense may overstate indirect costs for facility-based physicians if they are now less likely to maintain an office-based practice separate from their facility practice. To correct for this perceived overpayment, the CMS is proposing to reduce the proportion of the facility practice expense RVUs allocated on work RVUs to half the amount allocated to non-facility practice expense RVUs. This is arbitrary reduction to the indirect practice expense that will result in unintended consequences to patient care and will likely result in and incentivize further consolidation. Next slide. So this shows the impact on practice expense from this change. Table shows that facility practice expense RVUs reductions for these services are by about 40 to 60%, and total facility RVUs on average between 10 and 20% reduction. To demonstrate the significant impact on this policy, consider the impact on the 80503 pathology clinical consultation code for 5 to 20 minutes. CMS is proposing to decrease the facility-specific practice expense RVUs for this service from 0.2 to 0.09. Combined with the efficiency adjustment above, the total facility RVU for 80503 is proposed to decrease from 0.65 to 0.53 in 26. As this reduction only applies to services provided in a facility setting, the non-facility RVU for 80503 is instead proposed to move from 0.81 to 0.78 in 2026, a significantly smaller decrease. Next slide. As you may recall, the AMA and Mathematica conducted a practice expense survey in 2025. Survey in early 2025 submitted their results to CMS. The AMA had hoped the data would be used for CMS to update cost data used in their practice expense calculation. That data was also intended to be used to update the MEI weights for physician work, practice expense, and professional liability insurance. Due to the limitations in the data, CMS is proposing not to use any of the data for rate setting in 2026. CMS intends to work with the AMA to understand whether and how such data should be used in rate setting as part of future rulemaking. CMS has outlined some alternatives in the proposed rule, which we're continuing to assess, but nothing will happen in 2026. Had the Mathematica survey been accepted, pathology and independent laboratories would have experienced somewhere between a 10 and 13% decrease. Next slide. The following show the top pathology services and how they were impacted. This provides a summary of the non-facility reimbursements for the top pathology services. As is seen, while all services see an increase, payment for 2026, the increase is well below the 3.3% to the conversion factor. This again is largely due to the efficiency adjustment to the work RVUs. Overall, the 26 professional components rose by less than 1%. Technical components by 1 to 2%, and the global payments lie somewhere in the middle. Next slide, please. Following shows the summary of the facility reimbursements for the top pathology services. Again, the high volume services. I want to show this slide to demonstrate that CMS is proposing to reduce the indirect practice expense in the facility setting. The top services seem to have been spared such a cut. Rather, the change in payment for these services is the same as in the non-facility setting, again, largely driven by the work efficiency adjustment. Next slide. So I will now turn this over to Dr. Bucci, who will review the finalized changes to the quality payment program and MIPS requirements for 2026.
Thank you, Dr. McClellan. I'll go to the next slide. So those of you who have joined into these proposed rules and final rule webinars in the past will recognize this diagram. And as a refresher, what it illustrates is there have been two pathways offered under the QPP, MIPS and APMs. MIPS is the pathway for clinicians under the QPP unless a physician qualifies as a participant in an advanced alternative payment model. And as we've shared before, CMS has stated that, in fact, they want all beneficiaries in an accountable care relationship where physicians are in value-based payment arrangements by 2030. So CMS would ideally like to see traditional MIPS go away in favor of advanced alternative payment models. However, that's simply not realistic right now. And in the interim, CMS introduced a transitional pathway between MIPS and APMs called the MIPS Value Pathways, or MVPs. So we'll be spending some time discussing MVPs today because for the first time, CMS has officially proposed a pathology MVP. If we can go to the next slide. So since the inception of the MIPS program, CMS has been steadily increasing the requirements for participation. This includes both increasing the minimum number of points needed to achieve a neutral payment adjustment, as well as the percentage of all cases that need to be reported to CMS. So as some of you will remember, CMS has been increasing the performance threshold and the data completeness threshold. Fortunately, for 2026, I'm happy to report that CMS is maintaining both of these at their 2025 levels. And in fact, they're proposing to keep the 75% data completeness threshold through calendar year 2028 and keep the performance threshold at 75 points through 2028 as well. So this is a critical advocacy win for us. Previously, CMS had proposed to raise the performance threshold to 82 points, which would have resulted in approximately estimated 46% of MIPS eligible clinicians receiving a negative payment adjustment. It's a sign of progress that CMS recognizes that significant increases in the performance threshold and data completeness are really not feasible for clinicians to sustain. If we can go to the next slide. So as a non-patient facing physicians, pathologists are only scored on quality and improvement activities. Quality continues to be proportionally the most important, particularly for large groups. So CMS defines large groups as groups with more than 15 pathologists. And for large groups, quality measures constitute 85% of the total score. Scores for small practices are reweighed so that quality and improvement activities are each 50% of the total score. Non-patient facing groups and individuals automatically qualify for reweighing of the promoting interoperability category, and pathologists are almost never attributed to cost measures. Cost measures, if you don't know, are attributed based on trigger codes, and those trigger codes are codes that pathologists seldom, if ever, bill. So what you can see here is that anything below a score of 45 will qualify for a negative payment adjustment, while 45 points on the nose will result in no payment adjustment, and above 75 points, there's a positive adjustment. As many of you know, 75 points is no easy feat. It's something of a high bar, especially for larger practices. And so the CAP continues to advocate for reducing the burden for pathologists so that we can be successful in the MIPS program. Can we go to the next slide? As I mentioned, for the first time, CMS has now officially proposed an MVP specific for pathology. As we noted last year, there were two pathology measures in the dermatological care MVP, but because there were only two, this wouldn't be enough to make it usable for pathologists. Now, for 2026, CMS is proposing an MVP, all for us. And as you can see here, we're just part of a broader effort by CMS to expand MVPs to cover non-patient facing specialties, and diagnostic radiology is there as well. We strongly suspect, we have no reason to believe that they won't finalize the pathology MVP for 2026. So we want to take a closer look at what's included in that MVP. Next slide. So as I've described previously, MVPs are intended to serve as a transition between transitional MIPS and advanced APMs. And they were rolled out in 2023. And the number and scope has been expanding steadily since then. They are intended to be a coherent set of activities, so the quality, the cost measures, the improvement activities that ideally focus on sort of a single clinical topic or specialty. However, many of the elements of MVPs, such as promoting interoperability and the current population health measures, just don't apply to pathologists. Therefore, it's unclear how meaningful a pathology MVP really can be. CMS has been transparent, though, that they intend for all MIPS eligible clinicians to eventually be in MVPs, and that MVPs then would be the only reporting option. But the timeline for accomplishing that is unclear. In the 2026 proposed rule, they floated the possibility of sunsetting traditional MIPS in 2029, but that's not officially a proposal in the rule. But just reiterating that, they did mention the same time frame that they had in mind during a recent webinar. Next slide. So the proposed pathology MVP includes the pillars that you saw on the previous slide. CMS is proposing to include all of the publicly available QPP measures, 6 of which are owned by CAP and 1 of which is owned by the American Academy of Dermatology. Also, CMS is proposing to include 3 of the CAP's proprietary QCDR measures, covering bladder biopsies, biomarker testing in lung cancer, and skin cancer reporting, respectively. They're also proposing to include 4 proprietary QCDR measures from a commercial QCDR called MSN Healthcare. In terms of the improvement activities, the other category that pathologists are eligible for, CMS has listed a number of improvement activities in the MVP, but only a few are directly applicable to pathologists. And we'll come back and talk a little bit more about IAs in a few slides. But with respect to the MVP specifically, there's a limited number of IAs that are directly applicable to pathologists. Now, what the CAP has been doing is submitting new proposals for improvement activities for CMS to consider due to the fact that several improvement activities that have been removed from the program over the past few years were more relevant for pathologists. So we're trying to get a replacement improvement activities accepted into the program. As I mentioned earlier, the CMS is also includes population health measures and promoting interoperability measures in MVPs, but these do not apply to pathologists in single specialty pathology practices. Coming back to the cost category, though, the CMS is proposing one cost measure for this MVP, which is a requirement of MVPs to have a cost measure. And the cost measure that they're proposing is called Medicare spending per beneficiary. So this is a general measure that's intended to be, broadly applicable to Medicare providers and not specialty specific. However, it's not going to capture most MIPS eligible pathologists because it's triggered by billing, evaluation, and management codes in an inpatient hospital setting. This measure also exists in traditional MIPS, and rarely, if ever, is attributed to a pathologist. So just as with the improvement activities and in other ways, CAP is continuing to advocate to CMS to make this MVP for pathology as reasonable as possible and as meaningful as possible for pathologists to use. And specific things that we're interested in is having more CAP QCDR measures in the MVP to give practices more choices, to have more relevant improvement activities, as I mentioned earlier, and then also explicitly acknowledging that promoting interoperability and population health measures do not apply to pathologists. If we can go to the next slide. So moving beyond MVPs, CMS has begun considering how to move more clinicians into APMs. And as I mentioned previously, CMS hopes that the different conversion factors may incentivize clinicians to move to APMs. However, a major challenge, incentives or not, is that for many specialists, including pathologists, that there's just not an APM that they can meaningfully participate in. And while CMS has always stated that MVPs are intended to be a transition to APMs, exactly how this happens from a practical perspective isn't clear, especially for specialists. Now, in 2024, CMS published a request for information in their proposed rule, asking for input from stakeholders on how to enable a smooth transition between the MVPs and APMs. And in the 2026 rule, as a result of that RFI, CMS has now proposed a new mandatory APM called the Ambulatory Specialty Model, or ASM. And so participants in this model are identified as clinician specialty types, for example, cardiologist, interventional pain management specialist, who qualify either for the heart failure or low back pain episode-based cost measures in MIPS as of 2025. Therefore, even pathologists who might happen to evaluate cardiac biopsies or interpret a high number of electrophoresis assays wouldn't be included as mandatory participants in this model. So without going into too much detail, since the model doesn't really apply to pathologists, what we can see is that it appears that this new APM is functionally an MVP, or really two MVPs that the CMS has made mandatory. And the quality measures and cost measures in this APM are actually the same as the MVP. Unlike other APMs, the ASM also includes improvement activities and promoting interoperability. And so unlike other APMs, you can see where this is building on existing MVPs in certain areas. But the big difference being that clinicians are the participants in this MVP, not individuals. There's no group option. So although this model does not capture pathologists, the CAP is going to keep an eye on it and monitor developments closely to assess which MVPs the CMS will be targeting for similar conversion to APMs. And the proposed rule indicated that this effort is very likely to expand in subsequent years. Next slide. Beyond the proposed new MVP, CMS is keeping, as I mentioned, much of the MIPS program the same from the perspective of pathologists, especially the basic building blocks such as performance threshold, data completeness threshold, sort of the overall scoring policies, and the pathology specialty measure set. However, there are some changes to improvement activities, as we'll discuss again in a couple minutes. And additionally, CMS is proposing some changes to how clinicians can participate in MVPs. However, because pathologists have mostly not been participating in MVPs, and several of the policies are aimed at specifically at multi-specialty groups, it's likely that most practices will not notice a change at this point. Most of the policies aimed at those multi-specialty groups are changes related to the formation of subgroups, and formation of subgroups remains quite complicated, and the benefits for single specialty practices are unclear, so we're not going to get into subgroup-specific policies today. Next slide. Okay, as mentioned, they aren't changing everything in MIPS, and thankfully one thing that they aren't changing is the pathology quality measure set. So there will still be 7 pathology measures available for reporting by any MIPS-eligible pathology practice. None of these have been proposed to be removed for 2026. As always, there's the one measure in the measure set that is actually stewarded by the American Academy of Dermatology, as we become familiar with, although it mainly applies to pathologists. Next slide. Building on the specialty measure set for pathology, I'm also pleased to report that CMS is proposing to maintain a favorable scoring policy that they introduced that recognizes the challenges that pathologists face with respect to quality measures. As you may recall, in 2025, CMS established a new policy for specialties with limited measure availability, including pathology. So rather than assign the pathology QPP measures a cap of 7 points, since there are simply few measures available to pathologists, these measures are subject to a flat decile system, but are still worth up to 10 points. At the time, CMS noted that they would reevaluate which measures are eligible for this special scoring policy each year. And this year, in 2026, for 2026, the CMS is proposing to continue applying this policy to 6 of the 7 pathology measures. And the newest measure, QPP 491, is not topped out, so it's worth 10 points in any case. Next slide. So I promised to get to improvement activities. CMS is making some changes in the improvement activities category for 2026, including some that were finalized previously, but weren't scheduled to take effect until 26. So recall that improvement activities is one of the only categories other than quality that applies to pathologists in single specialty practices. And broadly speaking, the CMS is making changes in the inventory of improvement activities to align with the priorities of this administration, including introduction of a new subcategory of improvement activities called advancing health and wellness, as well as removal of activities that the administration considers unnecessary. 3 of these activities are in use by some pathology practices. Please note that these are activities were already suspended for 2025, and the CMS is now just proposing to formally remove them for 2026. In addition, CMS is moving forward with previously finalized policy that could affect single specialty pathology practices, and that is removing IACC1 and IACC2, which are actually regularly used by plenty of pathologists. However, that's not new. That was finalized last year. So hopefully practices have had some time to identify an alternative improvement activity. Unfortunately, the three new improvement activities that CMS is proposing can't be used by pathologists. One covers oral care, one covers detection of cognitive impairment, one covers patient safety and AI. And although that last one sounds promising, it's focused on requiring development of a new data collection field within patient safety reporting systems for IA attributable events. So it's fairly specific and narrow and not likely to apply for pathologists. However, CAP has submitted new improvement activities for next year for consideration by CMS, and hopefully that will help to fill some gaps in the improvement activity inventory. If we can go to the next slide. So the last thing we'll focus on is some proposed changes to advanced alternative payment models. CMS has revived a previous proposal and incorporated feedback from stakeholders, including the CAP, to improve what they had previously proposed. The background on this is that CMS determines who is in an advanced APM, and therefore exempt from MIPS. A clinician or practice does not submit anything to the CMS. The determination is done based on the practice, taxpayer identification number, and billing codes. Right now, that determination of who is a qualifying APM participant or QP is done at the group level and is based on billing of E&M codes. And CMS heard that some practices might remove specialists from their participant list if the specialists did not bill E&M codes, because those specialists do not increase the number of attributed beneficiaries for the practice. CMS acknowledged that that would be unfair, and they're looking into ways to address it. And what they're proposing here is to do qualifying participant determinations at both the individual and the group level, as well as to expand the scope of services that would attribute beneficiaries to an APM practice. CAP, along with the AMA and other groups, supported the idea in concept and provided, feeling that it would provide a more predictable, fair, and accurate picture of the beneficiaries treated by an APM. We have asked for more information about certain specific situations, though. CMS, has replied to our requests. We feel like they have adequately addressed our concerns, and overall, taken together, we think these policies are a net benefit, as they would tend to prevent pathologists from being shut out of APMs unfairly, while at the same time acknowledging the important role of pathologists play in team-based care. Next slide. So as I kind of alluded to earlier, CAP, we're in alignment with the AMA and many other specialty societies when it comes to protecting independent practices and the right to practice medicine as appropriate as doctors. And as part of this high-level principle, the CAP continues to advocate for maintaining traditional MIPS while also reducing the burdens associated with MIPS reporting. CAP is also investigating meaningful ways that pathologists and independent practice can participate in accountable care organizations and alternative payment models, but without being forced to consolidate or merge into other practices. Can we go to the next slide? As part of our commitment to independent practice of pathology, CAP continues to develop and maintain pathology-relevant quality measures and improvement activities and the Pathologist Quality Registry. And the registry supports several mechanisms of data entry, including working with practices directly or billing companies to help maximize your scores. We have excellent registry staff who will talk with your practice, help you navigate MIPS to maximize your bonus potential. The scoring, it gets complicated. It gets very complicated. So it's increasingly important to understand how to score best. Most pathology practices can score best using the pathologist quality registry and the quality measures it supports. So for those of you who rely on billing companies, we work with billing companies and encourage you to ask them to reach out to CAP on your behalf because the CAP's QCDR measures should be an important consideration in their scoring strategy for you. Here you see the email address. Please don't hesitate to reach out to the excellent staff at CAP to understand those measures and how to report them and what might work best for your practice. And I'll stop there and turn it back over to Dr. Saad for questions.
Thank you very much, Dr. Bucci. Thank you, Dr. McLaughlin, for those presentations. I'll now ask Ms. Yazdani to read the first question.
Thank you, Dr. Saad. The first question I have is for Dr. McLaughlin, and the question is regarding the Medicare physician fee schedule proposed rule. It seems that pathology is hit hard by these proposals. In a world of budget neutrality, who are the winners?
Good question. In budget neutrality, there are always winners and losers, and I think it's safe to say that primary care was the big winner here. Recall that the efficiency adjustment doesn't apply to time-based services, and primary care, for the most part, reports their services as evaluation and management services, E&M services, so they're not subject to that decrease. Also, primary care is largely non-facility based. They avoid the reduction to their indirect practice expense. There are also some other proposals within the proposed rule that are very primary care centric. This includes the expansion of the add-on E&M G code G2211 that was introduced a few years ago and was largely viewed as a way to prop up the E&M payments. Even though pathology was kind of hit hard in the proposed rule, I think it's important to note all the other procedural specialty areas also have seen reductions. So it's not just pathology. The other loser in this process has been potentially the AMA RUC valuation process. And I think many of you are aware that both HHS Secretary Kennedy and the CMS Administrator Mehmet Oz has focused on the AMA CPT RUC process and the valuation of physician services. So I think we're going to monitor this carefully as this may be signs of things to come where RUC times and RVUs are being reduced through the rulemaking process.
Thank you, Dr. McLaughlin. The next question I have is for Dr. Saad. It was mentioned that the One Big Beautiful Bill is for 1 year only. What does that mean for 2027?
So thank you for that question. As you may recall, for the current year, 2025, the conversion factor went down by 2.8%. And there was a continuing resolution at the end of in December of 2024, in which we were pretty optimistic that we could get that mitigated or reversed. Unfortunately, that continuing resolution failed, and ultimately the one that passed did not include any mitigation. There was a second continuing resolution in the first quarter that also did not include the mitigation for 2025. So down 2.8% for 2025. Looking at 2026, the One Big Beautiful Bill Act does include that 2.5% increase to the conversion factor, which when combined with other factors could be up to 3.3%. However, it's for 1 year only. So for 2027, that 2.5% would go away, and we have to advocate for 2027 for mitigation of the loss of the 2.5%. We will continue to push for an inflationary update as the ultimate solution to these unstable payments to the Medicare system. In the short term, we may need to have a year-by-year solution, but our ultimate goal is to have our fees tied to an inflationary update like other people that are paid under Medicare are, such as hospitals, ambulatory care centers, et cetera. So 2027, please participate in the advocacy efforts, including our Hill Day in 2026, and all action alerts to mitigate the decrease.
Thank you, Dr. Saad. The next question is for Dr. Bucci. Since the proposed pathology MVP isn't required, should I use it anyway? What's the benefit of it for my practice?
Yeah, and who is asking for an MVP? So you should, if you report the MVP, an advantage is you must report 4 quality measures instead of the normal 6. And since the MVP is new and we want practices to get the highest score they can, we would tend to recommend that practices who want to report the MVP go ahead and do that, but then also continue reporting traditional MIPS. The reason for that is that CMS will take your highest score if you report both. And so until it becomes clearer exactly which may be more beneficial for a certain practice and exactly how people fare in the MVP, the recommendation would be to give both a try because you'll be scored based on the higher score of the two.
Thank you, Dr. Bucci. The next question will be for Dr. McLaughlin, and the question is, how does the CAP plan to respond to CMS's proposed efficiency adjustment, both as it relates to 2026 and additional adjustments that could come every 3 years?
Thank you for that question. So the way we will typically begin the response to this is we will write a letter on the proposed rule outlining our concerns in general with all the items, but specifically with the efficiency adjustment. And then we will be seeking a meeting. We typically will have a meeting with CMS to discuss these issues. We will continue to understand why they develop the efficiency adjustment, and then maybe that can inform us as to how they intend to proceed over the next 3 years.
Thank you, Dr. McLaughlin. So the next question, again, is regarding the quality payment program, part of the regulation, Dr. Bucci. Do you think CMS will keep creating APMs and MVPs like the one in this proposed rule? Can CMS force us to be in an APM?
Yeah, I mean, I think that CMS will continue to create new models, both from MVPs and potentially from scratch. Creating new APMs is really a priority of this administration, given their focus on controlling costs. So there's a CMS Innovation Center that creates the APMs, and they just released another new model a couple of months ago that we mentioned the ambulatory specialty model. Fundamental component of that is the episode-based cost measures for heart failure and low back pain. As I mentioned, pathologists aren't eligible for the ambulatory specialty model because we're not captured by the episode-based cost measures that will be used to assign clinicians to the model if it's finalized. And at the moment, there are no episode-based cost measures for pathology at all. So we don't expect that there would be an APM for pathology in the immediate future. But for sure, we'll continue to work with CMS and that innovation center I mentioned to ensure that pathologists don't get caught or penalized for not being able to participate in APMs when they are aiming to get people into those types of models.
Thank you. The next question, again, is regarding the efficiency adjustment for Dr. McLaughlin. The question is, I'm confused by the efficiency adjustment. CMS makes it clear that this is for non-time-based services, but it appears that this adjustment has been applied to pathology clinical consultation codes, which are time-based. Can you confirm if this is in fact the case?
Thank you for that question as well. We definitely share your concern. You are indeed correct that the pathology clinical consultation services have been included as part of the efficiency adjustment. CAP will oppose the policy and will advocate strongly against it. We will seek clarification from CMS, and as I stated, we'll express our concerns in the letter, and then we will also meet with CMS on this and other issues. These are time-based services and very much modeled along the lines of the E&M codes, both time-based or MDM, medical decision making. So it is concerning that they included this under the efficiency adjustment. Maybe they just threw the baby out with the bathwater with all the other proceduralist services, but these are very much like the E&M code, so it's not clear as to why they did this. So we will advocate very strongly against this.
Thank you, Dr. McLaughlin. And the next question I have again is for Dr. Bucci. It seems like there aren't many improvement activities pathologists can use anymore. CMS has gotten rid of all the ones we reported in the past. What should I do?
Yes. Okay, so for 2025, CMS reduced the number of improvement activities that a practice needs. So you only need to identify one activity that 50% of members of your practice can do for 90 consecutive days. So they're less to choose from, but maybe less of a burden, and that can help to make it more manageable. CAP on the CAP website has a resource that'll help identify additional improvement activities that you may be able to use in 2025 and 2026. And the other thing, as I sort of hinted at earlier, is that we are actively working with CMS. We have written proposals to them for new improvement activities that would definitely be appealing to pathologists. And we are working vigorously to try and get those accepted so that they would be available for pathologists as soon as possible. So we'll see, but hopefully that will expand the number of options in the next year or two.
Thank you, Dr. Bucci. I'll now turn the program back over to Dr. Saad.
Well, thanks again, Ms. Yazdani. And could I have the next slide, please? I would like to encourage you to stay informed through the CAP. Follow the CAP on social media. Our Twitter handle is @CAPDC Advocacy. We're also on Facebook and we're also on LinkedIn. Please visit the advocacy page under cap.org. There's a lot of information there and it's updated and improved continuously. Also be sure and read our advocacy update newsletter that comes out every Tuesday afternoon and is emailed to you. And also please join PathNet. That's our CAP Grassroots Advocacy Network. And with that, it brings us to the end of our program. I would like to thank the panelists and the CAP staff for all their work and all their help. And I hope everyone has a good rest of your day. Thank you very much and goodbye.